So look, thanks, Jeff, for helping us with providing some feedback to the students about how to do well and pass the surgery OSCE stations. And I guess I wanted to focus on the formative OSCE that the students have just done, and then we'll talk about surgery OSCE stations in general, if that's okay.
Sure.
So the formative OSCE station, as the students may remember, was the one with the small bowel obstruction and the X-ray. And I was wondering if you could just give me an idea of some common mistakes or traps that the students fell into that maybe made them borderline or fail the station.
Okay, thank you very much, Neil, and hello everyone. Now, this was a pretty straightforward station for surgery, and the abdominal X-ray, which was an erect X-ray, shows a very typical small bowel obstruction, and the history offers that the patient had an appendicectomy as a younger person, and so we'd say, look, it's most likely adhesional small bowel obstruction. And so one of the early traps is that students didn't pick that it was small as opposed to large bowel. And I think any experienced doctor would look at it and say, oh, actually, that's a really straightforward small bowel obstruction. But we do go through this in surgery, in the quizzes, and this X-ray actually comes from the quizzes that I convene with you. So if you've got any issues, please go back and have a look at some small bowel obstructions on X-ray. Anyway, so that was the idea, was that you needed to identify some of the features that lead to the diagnosis of small bowel obstruction. And there are two ways of presenting it. One is that systematic approach, and that's entirely appropriate and thorough. And the other approach, which I really like with students, is when they say, okay, the most pertinent finding here is that of a small bowel obstruction, and let me explain why. And so there are two ways of doing this, either systematic or going straight to the answer. And look, that very much depends on your confidence at the time. Okay, so having made the diagnosis, we then move on and it becomes a communication station. And that's where you as the intern are tasked with presenting a management plan to the nurse on the ward. And this can be a bit tricky for you as students, because the examiner, who's of course is a consultant surgeon, suddenly becomes a nurse on the ward, and that's something where you have to suspend disbelief and accept that actually the examiner is now a nurse. And the first component is how do you actually present to a nurse, and we do need a management plan. Now, the management plan here for you guys is it's very straightforward. It's a nasogastric tube, intravenous line, intravenous hydration, catheter in, an analgesia and an antiemetics. And that's actually pretty straightforward. And you know what? This is what you're going to be doing with your teams next year as surgical interns. So every time you have an acute surgical case presented to the ward, you're going to be doing all of those things every single time. So I tend to advise you actually for common things like this, or whether it's an acute abdomen, a small bowel obstruction, a large bowel obstruction, even something straightforward like asthma or heart failure, think about a short list that you have ready to go in the OSCE, because then it will come out a lot easier and you don't really have to think about it too much. The list just tumbles out while you're thinking of other things. And so so the well-organized students got that list out really well. And then the nurse asks you, what do we have to watch out for as far as complications are concerned? And please remember that a small bowel obstruction, we operate on them because of progression and the cause of ischemia and possible strangulation. Most every student jumped to say perforation first. And I have to say, that's pretty rare in a small bowel obstruction. Ischemia, uncommon. Perforation, really rare. And it's always as a complication of ischemia anyway, or strangulation. And the other things that we do look for is like fluid and electrolyte imbalance, because you kind of get that third space loss into the bowel, into the obstructive bowel. And of course, the students who are excellent found that they were identifying a loss of nutrition, so the need for nutritional support as well. But really, it's about ischemia, it's about strangulation. Now, then you are asked to, in this station, how do you communicate those signs of deterioration? And so this is where you just have to identify how nurses are instructed, and it's about alteration in patient appearance and patient observations. And please don't say A, B, C, D, E. please identify, we're talking about pain, we're talking about high temperature, so pyrexia, we're talking about hypotension. These are all the common things that nurses measure for you all the time. And you have to ask the nurse, you have to instruct the nurse, and sometimes give them parameters when to act and how to identify who to call. So it's about communication here. Now, but please remember that we can't ask the nurses to identify peritonitis or peritonism. That's not their job. Their job is to identify alterations in patient appearance and alteration in vital signs. So I have to say, on this station, which I think is actually a pretty straightforward station, a lot of students kind of came unstuck as to how to communicate with nurses. So I tend to suggest, please go back to the wards and watch your interns and registrars, how they communicate in the team environment. So one of the things that we're looking for is how to get you up to a team player position. And because as an intern, you're actually going to be leading a team on the ward as well. Now, finally, an overall judgment we make of you is either called the global score, or there's a modification these days called the examiner's comprehensive judgment on process and performance score. It's a bit like a global score, and really it's just making sure that overall you're at the right level. Now, the examiners will make that judgment overall, and that'll be after you've left, and you won't get any feedback on this in the summative OSCE, but in the formative OSCE, we give you plenty of feedback as to how you've done. If you get through things quickly, and if there's more stuff that you could achieve in terms of more points to score, your examiner will take you back and say, "How's about this? Let's ask this again." And so there can be a little bit of leading. But please be aware that if we have to lead you to an answer, we are obliged to reduce the marks that you're offered for it. Okay, I think that's it. Neil, do you have any comments for me?
Thanks, Jeff. I mean, so many pearls of wisdom that you've just espoused in the last few minutes. It's actually amazing. I might just focus the students on a couple of things that I thought were highlights. And one was role playing. I think understanding the role, what role you've got and what role each person in the room has got is so vital. And I appreciate that seems so unnatural and that's the poor thing about OSCEs, I guess. But just understand the role, or you'll just be losing marks for no reason. Sure. And the other thing I would highlight as well is the importance of clinical placements. A lot of this stuff you just learn on the wards. I mean, I imagine if you've done your clinical, you've done your surgery term and you've seen a fair number of patients, the perioperative management of all of these conditions are pretty straightforward.
Sure. Okay. Well, just another thing, Neil, before you go on. Yep. On this, as you walk in, please make sure that you've read the trigger and you understand the trigger. It's always sitting there for you, laminated as well. And if there's any doubt, just focus back on the trigger, because your examiner is aiming through the trigger as well. Sorry, carry on, Neil.
Fantastic. No, I was going to just mention a couple of small minor details with which I noticed when I was sitting in on a few surgery stations, is that a number of students were able to make the diagnosis of small bowel obstruction, and then they thought their job was done. And not many of them then took the next step, which is, well, why has the patient got a small bowel obstruction, and then thought about the previous surgery and thought about the inguinal hernias and all those other things.
I'm absolutely in agreement with you there. And this is one of the things we do in our quizzes. We identify, hey, it's not just a small bowel obstruction, but small bowel obstructions are caused by hernia, adhesions, volvulus, intussusception, tumour. And we go through that again and again with the final year groups. And the ones who have done surgery, if they don't spit that out, well, I feel a bit sorry that they haven't been to the quizzes properly. So you're exactly right. At the final year level, we really do want you attempting a differential diagnosis.
Yeah, and that's clinical reasoning. That applies to all disciplines. So if a patient comes in with anemia, that's not the end of our job. Why are they anemic? So students really need to focus on the next levels of the patient management. The other thing I was going to point out, this is a minor thing, Jeff. Some of the students when I was sitting in talked about air under the diaphragm. Would that make them fail, or what were your feelings around that?
I would almost always kind of lead the student back to actually why might there be air under the diaphragm, and we actually go through this on the quizzes as well. So there's the X-ray. It shows the gastric bubble, and so the gastric bubble is air under the diaphragm, but it's contained within a viscus. And I then, in the wrap-up, we'd say, actually, if there's air under the diaphragm, the implication is a perforated hollow viscus. And those patients are really sick with peritonitis, whereas this guy is only moderately unwell. But patients with air under the diaphragm are really sick and septic, and we would almost always show the air on the other side. So the right diaphragm, and on the left side, you kind of can get the outline of stomach and outline of colon. We call that Wriggler's sign in abdominal X-rays. It's pretty uncommon, and we do lead you back if you go down that pathway of peritonitis from a perforation. We'll lead you back to that.
Fantastic. And then
occur.
And you mentioned a few of the things that the good students did. Because some of the students really want to know, how do they do well? How do they get above expectations or exceeding expectations from this station?
All right, no worries. So look, in the first part where you're looking at the X-ray, the better students will identify that it's a small bowel obstruction and identify the various causes of it and do it in a really systematic fashion. So do think of and mention causes wherever you can. In terms of the communication, the communication of the management plan, I'd love to see it as communication through identifying yourself as the doctor, as part of the team, and then go through it, and so you can actually follow the A, B, C, but just keep that in the back of your mind and think, okay, well, I'd like parental supplemental oxygen on this patient. I'd then like to put it onto this amount of oxygen flow, whether it's 2 litres or 4 litres or whatever, and then of course, then we're down to the intravenous line needs to be placed. Now I might put a spare one in, and then I'd put up intravenous fluids. Now we don't assess you for the type of fluid or the rate. But the really good students would say, oh, look, I'll just put up CSL and let's run that at over 8 hours to start with and see how it goes. And on fluids, let's make sure we then put a catheter in. So it becomes a conversation between professionals. And so it sounds fluent, and it sounds like someone has really done this before or been involved in it before. So it's fluent, it's clear and concise, and there's no doubt as to what the nurse's role is and what the expectations of the nurse in caring for our patient is. So it's about fluency. Now, equally, when we're talking about communication in terms of in the event of deterioration, it has to be clear, concise, and matched up towards deterioration points. So if the patient develops a fever, call me. If the patient's pulse goes above 100, please call me. And so on and so on. So it's got to be very clear and fluent in the way it's presented.
Okay, fantastic. Thanks for that. And I see that Mo has joined us. Thank you, Mo. We've just finished talking about the formative OSCE, but I wanted to maybe take a step back and talk about surgery OSCE stations in general, not the formative OSCE anymore, but surgery stations in general. What are some common mistakes? Maybe Mo, you can tell us. What are some common mistakes made in surgery stations in general?
I think the commonest mistake is people sometimes read too much into the question. They think that there's a trick in the question. Is rather than just looking at the task, it's a very simple, usually task that we ask the students. And we expect them to be interns. We expect them to appraise the situation as we do every day. Is very simple and straightforward. Don't read too much into the question. When the task says, look at the patient, assess their vitals, what do you think is wrong with them? If it's unwell, you just say patient's unwell. They're clearly looking at the vitals, their blood pressure is low, they have high temperature, so has low blood pressure, has a high temperature, therefore they're septic. There's no trick here, and then when you're looking at an X-ray, you look at the X-ray, you look exactly at what you see, just describe what you see, and it's very obvious. It's not too complicated. And so when people reading too much into the question, that's when they usually get lost.
Yep. Great advice. Jeff, any other thoughts about failing students?
Oh, okay. Well, look, if the student is going down the wrong pathway, and the best example here is that small bowel versus large bowel obstruction, the examiner will usually drop hints and make suggestions. And please remember, if an examiner says, are you sure? They're not testing your mettle. They're trying generally to bring you back towards the correct pathway. And so the examiners want you to pass. They really want you to get through the exam and to do your very best. And so if the examiner then says, well, you mentioned this and this, is there anything else you'd like to mention? Don't stand on your guns and say, nope, that's it. You might say, well, maybe I'll just go through that again. Is there something else I might have missed? And so it does become a little bit of gamesmanship in that respect. And equally, the examiners are very keen for the students to pass.
Yeah.
Very keen for you to pass.
Yeah, we don't want to fail anyone. Okay, so a common question the students are asking as well is the opposite of that, is that, what are some tips to do really well in surgery OSCE stations? Mo, do you want to go first?
Yeah, I think, remember, if you're systematic, and then you just go in a really nice systematic approach, that means most probably you will get not only answer the questions well, you will most probably answer more than what is needed, and you'll do much better, because the system allows you to be very fluent. That means you have plenty of time. You mention all the important things, and you'll have even extra time to actually add more. So systematic, I think, is one of the things that you always see as commonly with people who are performing really, really well, I think, and that's by far the biggest what I call a successful feature that I see in the well-performing students.
Yeah, fantastic. In fact, Jeff was saying very similar thoughts earlier. Jeff, anything else?
Look, I think, and I generally let students know they can kind of predict some things. And please remember that half of your surgical attachment is ENT.
Mm.
Please remember that the professor of ENT is Professor Peter Friedland, and you might have a look at some of his publications, and you might find that one of his publications was a GP guide to assessment of unilateral sensorineural hearing loss, acute unilateral hearing loss. But there are some things and other things you look up and they say, oh, these seem to come up quite commonly, and that's I don't know, epistaxis might be one. Interpreting audiograms, or interpreting what are they, Rinner's and Weber's tests. Interpreting we can't do, but be prepared for that, and be prepared to look at an otoscope and describe what an otoscope is, and then be not necessarily to do it because patients have been hurt, but to look at a photograph of a drum. So having a look at some of the atlases of otoscopy findings can be really useful. So there's certain things and you'll find all this if you talk to last year's final years and the year before, they'll tell you what to specially prepare for, what things are examined, because I don't know, if we're examining a patient in surgery, it's often we're looking for pulses, or we're looking that you can examine the abdomen confidently. Those sorts of things are kind of predictable.
Yeah.
Predictable.
Thanks for that. So there's only 2 months to go at the time that this is being recorded. Any advice as to what the students could focus on the remaining 2 months?
Absolutely. Please watch the interns. Pretend that you're an intern and shadow the interns as much as you can, because that's exactly the level we want you at. And so they're the wisest people to watch. The registrars are going to get really excited about specialist stuff, but the interns are the ones that we want you to reach that level. Consultants they're just off in their own orbits, I'm sure. But interns are the ones we want you to emulate.
Yeah. Mo?
Well, as Jeff said, my expectations of you is that you will be at a level of an intern when you finish this year, and that's you need to be. And the knowledge that we have shared with you in your TUTS, in your back to base teaching and LMS, is what we have given you to make sure that you can achieve and work and accomplish the tasks that are expected of you as an intern. So you cover that, you will be fine.
Fantastic.
So no need to go into the the weird and wonderful. You don't need because these are rarities and it's not expected of you to be able to achieve that. You know, you need to do the bulk of the work and be a good intern, good doctor. So all the information that we provided you, that is going to cover the necessities that will equip you to be that successful doctor.
Equally, practice presenting cases as if you're on the ward round. So
Yes.
practice. So watch, and when you're on ward rounds, please ask if you can present 1 or 2 cases during the ward round. So you're practicing in communicating with your colleagues in a succinct fashion, succinct and deliberate fashion. And in the exam, please avoid acronyms. Please don't stand up in front of me and say, oh, well, the answer to this is A, B, C, D, E. Because I'm going to say, yeah, I know the alphabet, but I want you to show how, and I know that that helps you back here. It's a mnemonic of some sort, but please, in the exam, if you say it, be very quick to say, and A stands for airway, I do this, this, and this. B stands for breathing, I do this, this, and this. Don't let it just sit as an acronym on its own.
Yep. Fantastic. Thank you very much. So I might just close it at that, but thank you very much, Mo, and thank you very much, Jeff. Much appreciated. I'm sure the students will really, really enjoy listening to you and watching you. Okay. See you later.
Neil, for organizing it as well.
Thank you very much.